We are Group 5, and our solution is on using AI to support palliative care and patient education.
The gap in continuity of palliative care after hospital discharge is a major challenge for hospitals, caregivers, and patients. After discharge, patients must manage complex medications, symptoms, and psychological challenges largely alone. The extra burden falls on informal family caregivers who often feel unprepared while also managing their own physical and emotional well-being. Health literacy, cultural attitudes towards illness, language, and access add complexity. Language barriers limit understanding of medical instructions, cultural beliefs shape decision making, and rural communities face limited access to specialist palliative care.
Why does this matter? Globally, 56.8 million people need palliative care yearly, yet only 14% receive it, a gap that peaks right after discharge, when 40 to 80% of medical information given to families is forgotten almost immediately, and nearly half of what's remembered is recalled incorrectly. This isn't just logistical, it's human. Higher caregiver burden is linked to stress, anxiety, depression, and sleep disturbances. Lack of follow-up also causes communication breakdowns that drive preventable ER visits and hospital readmissions. So this affects patients and caregivers, multidisciplinary care team, and healthcare system, which absorbs the cost of these avoidable readmissions.
Large language models perform well on medical exam style questions, but can still generate hallucinated responses, so they are not yet reliable and require clinician oversight. Palliative care specific AI tools remain at early stage with emerging research exploring symptom monitoring, communication, and shared decision support, but validated interactive educational tools for patients and caregivers are still limited.
Our proposed solution is PalliaBridge, an AI-powered platform to support patients receiving palliative care and their caregivers after hospital discharges. It has 3 key components: personalized education, continuous monitoring, and AI clinical support. First of all, caregivers will complete an embedded short questionnaire, as you can see here, while relevant clinical information is imported from the patient's discharge summary. Using this information, AI tailors educational content to the patient's diagnosis, treatment stage, preferred language, health literacy, and learning preferences. Instead of overwhelming the caregivers with long articles and complicated medical terms, PalliaBridge provides bite-sized videos, audios, and interactive guides to support the medication and symptom management, as well as providing any relevant community support services. Another crucial feature of the platform is continuous monitoring. This includes monitoring patients' health conditions via daily symptom check-ins, as you can see here. Caregivers can also self-report their stress, emotional well-being, and sleep quality, as well as their confidence in providing care via the Caregiver Wellbeing Portal. Based on the data, AI can analyze the trends to identify symptom deterioration and/or early signs of caregiver burnout. Finally, AI will automatically analyze the information in the patient and caregiver portal and categorize patients into a 3-tier system within the clinician portal. Green indicates stable symptoms and routine monitoring. Yellow recommends proactive follow-up, and red signals severe patient deterioration or high caregiver burden, which requires immediate clinical review.
This AI solution improves palliative care by bridging gaps in access and education, particularly in rural and marginalised communities. Continuous symptom and caregiver monitoring enables earlier intervention, shifting from reactive to preventative medicine. By combining education with ongoing support, the platform aims to deliver more personalised, patient-centred care. To measure the impact of our solution, we'll be looking at 4 areas. For patients, we will track the rate of emergency department visits and hospital readmissions within 30 days of discharge. We'll also measure changes in their key symptoms through daily brief symptom check-ins. Regarding educational components, we'll measure the engagement with educational modules by tracking the completion rates, frequency of assessing the materials, and confidence ratings. And finally, we'll measure whether the alerts are being appropriately attended to by tracking the percentage of yellow and red alerts that receive clinical follow-ups, as well as the time between the initiation of the alert and intervention. The people involved are the AI developers to build and maintain the platform, researchers to evaluate safety and effectiveness, patients and caregivers, hospices and community palliative care teams, nurses to monitor AI alerts and concerns, doctors to review high-risk cases and guide clinical management, and the resources that are needed are secure AI infrastructure, platforms for feedback, and the platform must be integrated into existing palliative care workflows. Devices should also be available for caregivers who otherwise could not access the technology to ensure equity.
Our solution directly targets 2 major gaps after palliative care discharge: information overload and unsupported caregiver burden. Kessels found that 40 to 80% of medical information is forgotten immediately, which weakens self-management after discharge. In palliative care, this matters because family caregivers often manage complex symptoms at home. WHO's 2025 review shows caregiver needs are diverse, but often poorly understood from a caregiver-centered perspective. Our AI responds by providing personalized education in the caregiver's language, literacy level, and preferred format, while using well-being check-ins to flag stress earlier.
For the challenges, firstly, in technology, digital literacy is the greatest concern. Most of the users are the elderly who struggle with language and app complexity issues. We could develop automatic translations and simplify interfaces. From the clinical perspective, healthcare providers face alert fatigue and burnout, causing delayed alarm responses, delays in treatment, and increasing stress. We could provide monthly questionnaires for workers to monitor their mental health. It is also difficult to synchronize with existing workflows, like teaching healthcare staff on the meaning of the alerts, how to treat and direct the patients from this new system. We could organize training programs. From an ethical perspective, obtaining consent for AI is difficult. 2/3 of patients in palliative care have cognitive impairment, thus incapable of giving consent. We could make it mandatory to state the consent preferences at 18, with the updates if they are proven mentally capable. Lastly, regarding implementation, development can cost up to $400,000 plus ongoing maintenance and training costs manpower. We can update pre-existing models instead of building new ones.